Friends, we're back at Memorial Şişli, and besides checking out the information about scoliosis, we also met with a neurosurgeon, one of the leading neurosurgeons at Memorial Şişli in Istanbul. And in general, we just filmed a video. Check out the one about neurosurgery. You had a ton of questions. What? How do you choose a neurosurgeon? It's a super technology-dependent industry, a technology-dependent surgery, so the equipment, the hospital, the presence of microscopes, navigation systems, CT and MRI machines, and even special MRIs that can be done right during the operation. All of that is extremely important for successful surgeries. Today, of course, the doctor mostly talked about brain tumors. By the way, the doctor mentioned that some tumors can be up to 12 centimeters in diameter. Can you imagine tumors like that? By the way, I asked the doctor, if we remove something from the brain, does that mean there are unnecessary parts in there? Let's see how he answered. Friends, this is Andrei Berzovsky, Channel Explorer, reporting from Memorial Şişli in Istanbul about neurosurgery. God forbid you or someone you know ever needs a solution to a neurosurgical problem, an issue with the brain or spinal cord that requires surgery. Watch to find out how to choose a clinic and what to pay attention to. What are the specifics of neurosurgical operations? This video covers all the questions about prices and everything else. Ask your questions in the comments, because today we're filming and talking with a neurosurgeon. Andrei Berzovsky. Don't subscribe if you don't care about your health. See you. Пока. Mainly, we focus on the surgical treatment of diseases of the brain and spinal cord. Diseases of these central nervous system organs are divided into those that require surgical intervention and those that are treated non-surgically. Non-surgical treatment options are handled by neurology, while surgical ones are the domain of neurosurgery. The best examples are diseases of the brain's blood vessels and benign brain tumors. These are the cases where neurosurgery alone is sufficient. But, as you know, there are also malignant brain tumors and metastases. In such cases, surgical removal of the lesion is performed first, and then, as a rule, radiation and chemotherapy are also necessary. For spinal fractures and injuries, after we perform surgical treatment, patients often also require physical therapy. So, friends, traditionally, Starbucks is a distinctive feature for us. The best clinics in Istanbul have a Starbucks on the premises. Maybe both options. For example, in cases of brain metastases, the patient already has an oncologist who refers them to us. But there are diseases that only we handle. For example, spontaneous brain hemorrhages, which are most often related to vascular disorders. In such cases, patients come directly to us, since these are emergencies. There are also cases with minor hemorrhages or patients from abroad who did not receive adequate treatment in their own country and are already in a critical condition. For example, a patient might have a sudden attack due to a primary brain tumor. In a department with insufficient care, they get an MRI or CT scan and a tumor is discovered. In such cases, the patient comes straight to us. We can name the top three. These are primary brain tumors, metastatic tumors, and vascular diseases of the brain such as aneurysms and arteriovenous malformations. Also, spinal tumors and deformities. We often see patients from abroad with these cases, since they are complex and require the latest technical capabilities and the most advanced equipment. First of all, any center with the necessary technical capabilities can and should accumulate experience. However, the field of neurosurgery really does require significant investment. For example, our microscope is the latest model. It's very expensive. For instance, the angiography system is extremely important. and it needs to be four-dimensional, like ours. We don't use two-dimensional angiography systems. We have simulation programs for spinal surgery. First, we model the surgery, and then we proceed to the actual operation. We have OAR surgical imaging systems that provide tomographic scanning directly during surgery. We can also do brain mapping. This is very important. I'll show you an example on the screen a bit later. We can do brain and nerve mapping before surgery. And during the surgery as well, which is very helpful, we have a navigation system, like in a car, that shows the exact path to the tumor in the brain. It helps us reach the tumor without affecting other areas. Of course, we don't use all these technologies in every operation. Only in cases where it is necessary. There are risks, and they are the same for both local and international patients. First of all, it's important to understand the organization of the brain. It's a topographical organ. Each area has its own specific function, so the location of the tumor or damaged vessel is crucial. Where is it located? What is this area responsible for? If, for example, it's responsible for motor skills or movement, then if complications arise, motor function may be affected. If it's the speech center, then speech function is at risk. If it is a hormonal center, then hormones. But if the area being operated on is in the so-called silent zone, then there are no risks to brain function. Overall, the general picture when there is a risk looks like this. Basically, just like in all surgery, you need to understand which areas are adjacent to the area being operated on. Those are the ones that are at increased risk. First, we ask all our patients to send us all the medical tests they have, including scans, reports from their local doctors, and examination results. This is very important because a doctor who has personally seen and examined the patient may include important medical details in their report that the patient themselves might overlook. The preparation process usually gets delayed because the patient might have, for example, heart or liver problems or other complicated related issues that the patient might not mention at first or might not even know about, not realizing how important these details are. Usually, the process is organized as follows. If there are no additional problems with the patient, 1 day is set aside for preparation. Then, the surgery is performed. After that, regardless of the patient's condition, even if it is perfect and everything went brilliantly, the patient spends a day in the intensive care unit. This is part of our routine. We work with the brain. It's important to keep the process under close supervision. The patient stays in the hospital for 5 to 10 days. At the end of this period, if we see that the patient truly has no serious issues, we let them return home to their native country. So, you should plan on spending at least 10 days in Istanbul. This is usually not required. However, if any problems arise, then we may recommend physical therapy and rehabilitation. Our clinic has a robotic rehabilitation center equipped with the latest technologies and robots, one of the best in Istanbul today. But, as I mentioned, such a need rarely arises since the surgery is performed using high-tech equipment that allows us to avoid risks and damage to important centers in the brain. Of course, that's not the case. As I said earlier, each area of the brain has its own function. For regions that are far from the surgical site, there are no risks. Every single cell in the brain is important. You can't say that the surgery will have absolutely no effect at all. There are areas we can predict, and there are unpredictable parts of the brain that can't be assessed from the outside. For example, if there's a movement disorder, you can predict and understand the mechanism behind, say, a hand movement. But if someone has difficulty performing certain actions during mathematical calculations according to Zell, that's almost impossible to predict. This function belongs to the so-called silent zone, Or maybe it would be more accurate to say the visualized and non-visualized areas of the brain. Here, take a look. This is an example of a patient. He embodies many of the things I mentioned earlier today. The patient is a 66-year-old man. A lesion was found in his brain that looked very much like a metastasis. As you can see here on the screen, this is the lesion. This patient was also later found to have a metastasis in his spine. The distinctive feature of this brain metastasis is that it is located in a critical part of the brain responsible for motor function. In other words, it's in the movement control center. First, we performed a functional MRI for the patient and did tractography, which showed the course and structural changes of the brain's neural pathways. Next, we performed the surgery using navigation, and as soon as we opened the skull, we mapped the brain. We identified which area is responsible for which function, one for finger movement, another for leg movement, and so on. This was done to determine which side would be safer for the surgical intervention. After that, we removed the tumor under a microscope. This patient did not experience any motor function impairment. There was only temporary weakness in the fingers of the left hand, which resolved on its own within a day. But if we were talking about the right frontal zone, there wouldn't be such risks. That's why it's called a silent zone. But of course, there can be isolated cases, for example, difficulties with mathematical calculations, which I mentioned earlier. This cannot be predicted. As you can see, this same patient has metastases in 2 of the spinal vertebrae. Since they were pressing on the vertebra, they thinned it out, which ultimately led to it cracking. As you can see, this also caused compression of the spinal cord. This is a compression fracture of the vertebra, but it occurred due to the tumor, plus there was also compression of the spinal cord. That's why this patient needed surgery in this area as well. First, we performed brain surgery because the patient had already started feeling unwell. Then, 4 or 5 days later, we performed surgery on the spine. This patient was diagnosed with colon cancer. The tumor was removed, a graft was placed, and then reconstruction was performed by fixing at 6 levels. Right now, this patient is still in the hospital after the surgery. The spinal surgery went very well, without any problems. Here, please take a look. The reconstruction is clearly visible in the lateral view. And from this angle, you can clearly see both sides. The patient is feeling great. So, our part of the work with this patient is finished. From here on, the medical oncology department will take over his treatment. The patient will still undergo chemotherapy and radiotherapy. Are CyberKnife and linear accelerators competitors to neurosurgeons? No, we work together in cooperation, in close collaboration. We believe in the power and success of teamwork. Every new stage in the development of neurosurgery will be better than the previous one because technology is advancing, and so is our field as a whole. Neurosurgeons have a saying, "Fine instrument, fine surgery." That says it all. The better the technology, the better and more successful the surgery will be. We are a field of medicine that doesn't fight against technology, but on the contrary, uses every possible technology to improve surgery. Our future will only keep getting better and better. So young people should really think about this when choosing their specialty. I'm not even sure, probably about 12 centimeters in diameter. We often remove large tumors because many patients seek help late, since they don't always show symptoms of the disease right away. We've had patients with tumors that were 12, 14, even 16 centimeters. But honestly, I don't really keep any statistics on that. The success of neurosurgery always depends on the type of tumor being removed. These huge tumors I mentioned don't show any symptoms at all. They grow slowly over the course of years, and they are benign. These tumors grow so slowly that the body adapts to them. If such tumors are successfully removed, the patient has no problems at all. The danger isn't in the size, but in the type of tumor. A large benign tumor is much better than a small malignant one. And of course, it's best not to have any tumors at all.